Thank you.
Dr. Sall, thank you so very much for an excellent presentation. Question number one, do you have current compliance data for oral appliance therapy?
Current compliance data.
I think they're referring to how comparing to CPAP, because we know what that's about.
Well, you mean me personally through my office?
No, I think the question is in general. Okay, the second part is there a way to measure objectively using technology? You may be aware of Brabon,
Sure.
and they have for many years had a project where they had an implanted electronic device that apparently could measure compliance. So I think what we dentists are saying, how do we fight the medical world that says, well, we can measure every minute. We all know it's 40 to 50%. So I guess the overall question is, what on the horizon do you see as implantable compliance devices that we can put in all oral appliances?
Well, that's a great question. And I think, we all know that compliance is an issue with CPAP, and compliance is higher in oral appliance therapy. And then when you look at effectiveness, it takes compliance into effect. And the thing that we are working at in ProSomnus is to be able to have continuous monitoring for compliance. And I would say just stay tuned, because this is very high on our radar as to what we think the industry needs. And I think that, the issue with the compliance chip, the Brabon chips, has been reliability and how long the chip's been lasting. There's been issues with it. There's a company, Thermon, that has a radio frequency out of, I think they're out of Austria. And this is something I think is very important to the industry, because we can do an efficacy test one night and it can show a good result in oral appliance therapy. But then what follows is, well, how do you know the patient's wearing it the next night? So I think compliance monitoring is something that all the major manufacturers are working on, and it continues to evolve. I think you're going to see within the next year or two that it's going to be an area where we're going to have good information on it and reliable compliance monitoring chips.
Excellent. One of my favorite passions is to wish I was a fly on the wall of all kinds of environments that I'm so curious about. So my question to you, Dr. Sall, because you're both a dentist and a physician, and given that the medical world knows that we don't have current compliance, is there a general feeling, however, that they know our appliances work generally well, and they know that compliance is quite high, and they know they can't dispute the low compliance of CPAP? I mean, is there that awareness, or are we still siloed where we're the enemy? You know what I mean?
I think that's a great question. I think we're still siloed in that we're the enemy. I think, to me, the most important thing is what we call effective AHI, or SARA index, or mean disease alleviation. Those are three critical concepts that everyone must understand. And it really has to do with effectiveness, takes into compliance. And I'm sure you're all familiar with Sestuli's paper. And it looked at, there's a graph that looks at high compliance and lesser efficacy is probably equal to the same effectiveness as someone who has high efficacy but low compliance. And so I think that sleep physicians, a lot of them still think in terms of, well, it has to be an AHI of under 5 to be a success. And really what it comes down to is, if a patient wears their CPAP half of the night and takes it off, and there's more REM concentration during the latter part of the night, then really what's happening is it doesn't matter what the machine shows for the 3 or 4 hours that they're wearing it. Really, what does it show for the day as a whole, for the week as a whole? And so I think we're still fighting that battle. And I think that compliance chips and oral devices, I really feel should be the standard going forward. And, the major companies, SomnoMed, ProSomnus, they understand that, and they're working diligently on that.
Wonderful. I often ask my own patients when they talk about compliance and how much they hate it, and I say to them, "So would your physician be okay with you taking your blood pressure pills like once a week or every other night, or would you even think of that?" Of course not.
Well,
And
that's a great point because we define compliance as 4 hours a night, 4 to 5 hours a night, 7 out of 10 nights of the week, or 7 to 10 nights. So if you look at the time that the person's not wearing the CPAP, the reality is they have a tremendous amount of hours where you can be considered compliant with CPAP, yet the number of hours that you're actually wearing it is quite small. And so I think I have to laugh because the reality is CPAP is the best form of treatment if you wear it all night, every night, and you never take it off. Okay. And as soon as you're not in that category, it becomes less effective. And so I think oral appliances, we have trouble with sleep physicians still who don't embrace it. I mean, I see every day in my office somebody who has mild sleep apnea, was never offered an oral appliance, and they never even heard of an oral appliance, And, the part of that really, I think, is that CPAP is marketed by two huge companies, Philips Respironics and ResMed, and they have a lot of money for marketing and advertising and brand awareness. People know about CPAP, but most oral appliances are made by small dental labs, and some are made by medical device companies like Somnomed and ProSomnus, some of the bigger companies, maybe Panthera. I don't know if they're considered a medical device company, but be it as it may, they just don't have the ability to market their product. And we still suffer in the industry very severely by just not good market awareness.
right. Okay, this has been a good sidebar. I better keep track of my attendance here. So, next question. What is the role of EPAP for treating OSA?
That's a good question. EPAP is something that I think it's fallen a little bit into disfavor. What happens is the airway tends to collapse in expiration, not inspiration. And so the problem with EPAP is that it has a fixed resistance. And that's really the problem with it. And I think it was popular for a while. I don't see too much of it used. I think it probably has a role in people if you can get it, if it's covered by insurance again, and person wears it. But the problem is you can't vary the pressure. It's a fixed pressure. So I don't utilize it in my practice at all.
Okay, the sub question was as a standalone treatment or in combination. Any thoughts?
EPAP.
Yeah.
Well, I think again, if a person has nasal airway obstruction, that and the airway is collapsing, and the EPAP, what it's going to do is it's going to act as a one-way valve to keep the airway open or increase the chance of the airway staying open during expiration. And so I think using it with an oral appliance would probably be efficacious. Again, when it first was marketed, I looked at it, used it a little bit, and then quite frankly, I just don't ever see it anywhere anymore. I don't know if it's marketed in Canada or what, but meetings I go to, I don't even see it anymore.
Okay, good. Thank you. Here's a comment about an excellent presentation, Dr. Sall. Thank you very much. Another one, excellent presentation, Dr. Sall. The Viva procedure seems promising. So how many patients would benefit from internal nasal valve improvement? What are the risks for this procedure? Any adverse results?
Great question. I've done about 85 of them, and I've looked at results of with respect to complications. I would say that complication-wise, there really aren't complications to be concerned about. There's some crusting and scabbing, which is temporary, and that improves over time. I would say not a complication, but sometimes people get less than the desired event, response. And, one of the things that I've learned in my career is sometimes you push the envelope. I mean, I've done oral appliance therapy over full dentures, and I've done it quite a few number of times. And is it an ideal situation for it? No, it's not. We all know that. But So I think that sometimes people get less than the perceived result. And usually I can predict that in advance. A person who's had 3, 4 nasal surgeries, who's had a no, they can't breathe at all through their nose, they're not really a great candidate for it. But a lot of times I will offer that to them, or not a lot of times, a few times that's been offered to them because they're desperate to breathe through their nose. Complications is a really a non-entity, to be honest with you. I would say the biggest thing might be is that you have to be realistic in your presenting it to the patients as to what they're likely to improve. You know, look, if they have extensive allergies, opening up the nasal valve doesn't change their allergies. It just mechanically opens up a constricted area.
Okay. Next question may seem to be setting you up, but given that you are obviously connected with Prosomnus, Dr. Sall, do you have a favorite oral appliance, and how do you decide which one to use?
Yeah.
Of course, it's Prosomnus. Keep saying Prosomnus. I think Wendy's here. She's recording everything that goes on.
You mean there are other appliances out there? No, I'm just
apparently, they're
well,
struggling.
look,
They're struggling.
I think that you know, it's interesting. I've listened to lectures. I've been doing this for a long time. You know, dental sleep medicine for about 25 years, but in practice for 41 years. So, you know, I think that with respect to appliances, really, there's many different appliances out there, and I think that what makes me favor Prosomnus is the ease of insertion, the profile, the ability that, you know, one of the things we've studied at Prosomnus is that the precision of the bite. Okay. And I think that we know that we've done all sorts of studies on tooth movement. One of them was done, I forget, it was a Canadian dentist that did it. Can't think of his name right now, but looked at tooth movement. The biogunk is minimal with the Prosomnus. It's a true precision appliance, and it's tolerated real well. And now that they came out with their Evo device, it's really, I think, in the industry should be the. I think anybody who does oral appliance therapy should consider doing that for the majority of their cases. We all have our favorites. There's people that like, you know, the nylon appliances, the Penteras. There's people that like TAP and Herps appliances. But I think that this field continues to evolve. And I think the technology, the precision, the ease of insertion, the minimal breakage, the hygienic aspect of it makes it my top choice. And, you know, I'm a consultant to Prosomnus. I don't get any special pricing. I don't get, I'm not paid to use their appliance. I can choose whatever I want. And my number one appliance 98% of the time is the Prosomnus Evo appliance.
Okay, well done. This is obviously an attendee who's also a patient and his own therapist. I've tried combination therapy and struggled with oral seal. Question, is there a need for tape?
Yeah, you know, that's a great question, Dave. Mark Murphy, who's in charge of dental education, I'm sure most of you know him at Prosomnus, from Prosomnus, is a big advocate of taping. And I think that if the person, excuse me, tolerates taping and they have the micropore tape, you can order it on Amazon. It's pretty cheap. Yeah, I mean, if you can't get a good lip seal, and you see, the problem is if you tape your mouth and you have nasal obstruction, it's going to be hard to breathe. So, but I think certainly for people who open their mouth, taping can be a great adjunct to compliance, particularly in combination therapy.
Okay. Next question is curious to see if you have many patients on combo therapy, in other words, CPAP and oral appliance.
I do. You know, it's interesting. I've always believed my philosophy was a patient want. When a patient comes in and they're on CPAP and they're happy, I never put them on an oral appliance. I mean, it would be foolish to do that unless they're asking for it. Okay. And there's patients that I've used combination therapy in a couple situations. There's people that have CPAP, they tolerate it, they travel a lot, and so they use the oral appliance when they travel, the CPAP when they're home. And then there's people who they use CPAP. I make them an oral appliance, and they just like wearing both because a lot of times, you can decrease the pressure. I have not utilized in my practice fancy interfaces to join the appliance to the CPAP. I don't really have experience in that. When I do combination therapy, I have them wear an oral appliance and the CPAP, and I don't see a necessary need to connect the two. I guess the advantage of connecting the two in one piece in some of these sophisticated interfaces is takes a little pressure off the teeth. You may tolerate it better. But I use combination therapy probably 5-10% of the time, if I had to guess.
Okay, good, thank you. Now some specific questions about nasal hygiene. Would you recommend daily saline rinses for the nose?
It's a good idea because, again, the nose warms and humidifies air, and that particularly in northern climates, most of you folks are in Canada. It's pretty cold in the winter and it's dry, and you get more nosebleeds and more congestion. So I think that using nasal irrigations or nasal saline or the NeilMed solution is great. I suppose if you don't really have a nasal obstructive issue, then it's not necessary. But it's certainly, nasal saline is cheap, it's easy to use, and it helps people with just hydrating the mucosal surfaces.
Most of us in the cold north have been watching TV for 2 weeks to cheer on our Canadians at the Olympics. And I can't tell you how many times I saw a commercial for the Navage machine.
Oh, really?
The
Yeah.
automated one. Do you have any
Yeah.
experience in that? Do you know
Yeah,
about
I
it?
have patients. I have patients on that. It comes down to what a patient's willing to do.
Right.
And I think that it's certainly a good form of treatment and helps with nasal obstruction. It's much safer than using Afrin. When you use Afrin, there's a condition called rhinitis medicamentosa, and what it means in English is a stuffy nose as a result of the vasoconstrictor. People who have trouble breathing through their nose, they can get addicted to vasoconstrictors very easily because they put it in their nose, it shrinks down the nasal membranes. Then there's a rebound effect where they get vasodilatation. So what happens in essence is the more they use it, the more they have to use it, and then they get addicted to it.
Right.
So saline is certainly much safer, and you really can't do much harm with saline or lavage or any of those things that are out there.
Navage looks to me like a modern version of the neti pot. It's automated.
Yeah, that's really what it is. Yeah.
So the guys use the Navage because you squirt it. The ladies mix all their lavender and stuff and do all that. And the guys. Okay, so back on the same topic. Are you familiar with xylitol-based nasal hygiene products such as X Clear?
I am not familiar with that.
Okay. Oh, okay. This is stimulating a lot of follow-up questions. Can you use just water for nasal lavage, i.e., in the shower? Tip your head back.
I suppose you could, but you'd be better off using the saline spray because it's more physiologic.
Okay. I've heard about rebound congestion from too frequent nasal flushing. Can you comment on that?
Well, I have not seen that. I've seen rebound vasodilatation from the use of Afrin and neosynephrine, which are vasoconstrictors. I suppose anything that, I'm just surmising, so to speak, that if you irrigate like a maniac, you're probably going to traumatize the tissue a little bit. And, if something's good to do once or twice a day and you do it 30 times a day, then it becomes less good.
Right. Nasal iodine spray used prophylactically.
Nasal what?
Iodine spray.
Yeah, I wouldn't recommend that or advocate that.
And the subtext is using it prophylactically before going on a plane during COVID times. I don't have a clue. I don't know what that's about.
Yeah, I've never been asked that. I haven't really thought about it, but
Oh,
I would
okay.
say that Uh, well, in the last 2 years, I've probably flown 25 times before and after vaccine. And I
Right.
wore an N95 mask and I wasn't really thinking about putting anything prophylactically in my nose. I did
Okay.
get COVID actually.
Oh, did you?
Uh,
Okay.
yeah, I got the Omicron. I wasn't very sick, but
Okay. Okay. This is Dr. Alter from downtown
Fine, Mike.
Toronto. Yeah.
Thank you. In the same way that I've seen some people readjust their TMJ by opening their mouth and moving it side to side, I've seen some patients who do something similar with their nose, where they've had nasal surgery, and then still they're doing
there's
things and
structure.
sniffing. Is that a valve problem? I know you can't diagnose, but what is that likely caused by? That they've had their surgery and yet they're still like they're blocked, but they
Well,
breathe
I mean,
for 2 seconds and then they do the movement.
I'll tell you a very interesting thing is that I was on the golf course in Arizona, and I met a guy, and actually his brother's an ENT doctor, and we were playing golf. I had just met him, and we're on the eighth hole, and he was doing essentially everything that you just said. Okay, so I walked up to him, and he had either 2 or 3 nasal surgeries, and 2 of them were done by David Kennedy, who is like the father of endoscopic sinus surgery. He was at Hopkins and he was at Penn. I mean, so he went to one of the true masters, and he still had trouble breathing through his nose. So I walked up to him on the right outside, on the green, and I said, "Hey, let me try something on you." So we're standing there, and I did the coddle maneuver on him, and his breathing improved quite a bit. And I ended up trying to find somebody for him to do the Vivera, because he had either 2, I think it was 3 nasal surgeries before. And he said, "Well, will you do it?" And I live in Syracuse. He lives in New Jersey. It's about 5 hours away. So he drove up here and I did the procedure on him. But he was doing exactly what you're describing. And he had a nasal valve problem. And he had a little bit of a stormy course because, again, it was somebody that had had 3 surgeries before and probably wasn't the best candidate. But I think the reason why he was doing that is he had a problem in the valve, And so I did his surgery. It was back in October. I just talked to him a week or 2 ago, and he's doing great now. But yeah, I mean, I think that's what it is. Sometimes people get nervous little habits. If you treated temporomandibular joint problems, I'm sure you've seen people who say, "Every time I do this," and they move their jaw all over the place, it hurts. And I'm thinking, well, why are you doing that? That's a parafunctional activity, right?
Yeah.
So, part of it could be valve, part of it could be just a nervous thing. Who knows?
They do it because it
Thank
feels
you.
so good when they stop.
Yeah.
Now,
Yeah.
now, Dr. Sall, a very personal question. After you did the caudal maneuver on your colleague, did he win the game?
No, he was a partner in my tournament. It was right after the surgery afterwards. And it was
Okay.
about 2 weeks after. He was still having trouble breathing because he was in the immediate post-op period. It takes about 6 weeks.
Right, right. Okay,
And,
thanks. What is the cost in US dollars of the VIVAR procedure? What is the cost in the States for the procedure you just talked about?
Well, so here's what happens in the US. You bill, and what you get paid is what you get paid, because the insurance companies are all different. So I think the reimbursement on it is usually around, on the low end, about $1,300, on the high end, about $1,800.
Sadly, and we don't have to worry about that in Canada because we don't have any access to any of that at all. It's all public money, as you know.
Yeah.
And in Ontario, where I am, from complaining to your family doc about snoring or sleep apnea to getting a CPAP machine will set you back $300 to $400 totally for all the sleep studies, all the professional visits, and the provision of the CPAP. And those of us in private practice have to charge at least $3,000 as a global fee for, the 6 months it takes to do the whole process. And it's a non-starter for a lot of people because it's 10 times more expensive. Like, do you want a Volkswagen or a Tesla? Well, they both get you to the shopping mall and they get you back, but that's the problem.
Is most oral appliance therapy in Canada, or does it depend on the province, fee for service?
It's all fee for service, and every province is different. And I can see a number of colleagues in at least the Western provinces. So does anybody from Western Canada want to chip in and tell us what their experience is for fee for service for dental appliances, sleep appliances in their province? In Ontario, it's zero.
So there's no coverage. It's all fee for service.
Yes, that's right. That's right. Oh, sorry. Well, our dental insurance, for folks who have third-party dental insurance, it's not even recognized in Ontario as a service,
Hmm.
And I was involved in leadership 10 years ago, and in Canada, our association is our union. We pay those guys money every year to run the place, and they can't even put a value to the provision of a dental sleep appliance for patients in our province. It makes me crazy.
Yeah, you know, well, I will tell you this, is that I was in, Prosomnus has introduced their products in Europe, and I was in London in October. We had 15 doctors from 9 different countries, and the European model is quite different. It depends on the country. They're all, you know, slightly different, but you know, in the European, particularly the Netherlands, Belgium, they tend to favor an oral appliance first, and it's widely covered by insurance in some of the countries. Italy's not as good. Spain, I'm not sure about. In the UK right now, there's a 2-year waiting list to get CPAP. 2 years.
Oh my goodness. So Roger, a colleague in BC, says fee for service or extended health coverage at 100%. So Dr. Sall, extended health for us in Canada means third-party insurance for most of the medical services not covered under the social assistance program. So like wheelchairs and physiotherapy appointments and eyeglasses. And most of those insurance companies still know the 10 to 1 ratio. So they'd rather approve a CPAP over an oral appliance. And in my practice, we spend a lot of time coaching folks to, you know, go after them and keep good notes. It's different. So Roger's telling me BC could be up to 100%. It's just not easy. That's the problem.
Are people willing to pay for oral appliance therapy fee for service in Canada as a whole?
Well,
If they value it.
well, I mean, I'm in a limited practice, so that's all I do is TMD and sleep, and about 50% of our patients come from former patients. And I tell you, you fix one person, they got 5 friends coming, and
Right.
I mean, I would like to be busier, but I constantly am getting folks either off of CPAP or wanting oral appliance because they were afraid of CPAP or they refused it or whatever. They tend to be more educated folks who've done their research. They've gone to websites. They know it exists. They talk to their friends. Before I get to meet them, they've talked to my front desk for, you know, a number of times, and oh, this works. Oh, okay, so come on in. Once they get one, of course, it's like, why didn't I do this years ago? But
Right.
you know, I'm pretty biased because this is all I do. But I know what a small percentage of patients that I'm helping, even in my city of London, which is like 400,000 people. Not much. So, any more feedback on fees across the country, folks? You can send it in by the chat box if you'd like. I think I read about Roger. Yeah, I think we're looking at hodgepodge of 10 provinces and 3 territories, and they're all provincially regulated, and we don't have the insurance system that you have in the States. I think in the States, dentistry could be a lot more profitable.
Well, you know, the challenge with oral appliance therapy in the US is that, you know, you need a consultation with a board certified sleep physician, a sleep study, and then it comes down to who can order it, a dentist or a physician, and then who can interpret it. And then usually the dentist needs a written prescription from the sleep physician for OAT, for oral appliance therapy, and then insurance will cover it. And during COVID, they started to relax some of the laws on face-to-face, and telemedicine consultation was sufficient. But I think that sleep dentists in the US still struggle because they have to interact with the sleep physician who has to give them the prescription, who has to believe in oral appliance therapy. I think the ones that have built big practices, if you look at the fee-for-service and insurance model in the US, I would say that there's very few people that do significant number of oral appliances who do not participate with insurance. In some of your major cities, maybe Chicago, San Francisco, LA, New York, there may be some people who are able to do 100% fee for service oral appliance therapy and have, success in that arena. But the majority of the people that do a significant number of oral appliances are in the insurance driven world. And the reimbursement is all over the board. It depends on the insurance company, and that's one of the challenges. And, I think that it's still a struggle in the US. The people that have built big practices have spent a lot of money on marketing and advertising. Some do direct to consumer radio ads, billboards, things like that,
Right.
But I think still the number of people that end up, the majority of the people, they want it covered by their insurance in the US because it's a medical condition. And if the dentist provides the oral appliance therapy, it's medical insurance, not dental insurance. They have medical insurance and they want it covered. And I would say in my practice, there's, in a given year, I probably have less than 10 people fee for service. The rest is insurance driven.
I think when you and I were chatting earlier, I told you I've probably spent the last 25 years traveling to all sorts of cities in the States for the education I now have. And I got a really good inside look at the other side. And I came to realize that the practice of medicine is pretty much the same on both sides of the border. In Canada, it's a profession run by a bureaucracy. And on the other side of the border, it's a profession run by a business model. And those two B's could not be further apart.
That's right.
And my assumption and my question to you is, because the business of medicine and dentistry is integrated, is it not possible to form better alliances with the medical partners, because you're basically fishing out of the same pool and you need to know what dentistry can do, and you don't have to be siloed because it has a beneficial effect both ways. Whereas in Canada, as you've said so many times, I don't know how many sleep studies I've read where the word oral appliance isn't even mentioned,
Yeah.
and their score is 8.9.
Yeah.
Makes me crazy.
I think that one of the things we need to do in the industry is change the mindset and the behavior of people. And I think that so many of us, and I'll use an analogy in dentistry, if you've used a certain impression material, PVS, let's say, in your career, and it works for you, you don't want to change it. Somebody comes in and they show you another one and the properties are a little bit different, the mix time's a little bit different. You don't want to use it because you're comfortable with what you use. And I think the challenge in our industry is that CPAP, it's almost like a lot of sleep physicians think OSA equals CPAP, regardless of the severity of it. And we actually, I'm about to start what I think is a monumental study. We're in the final stage of FDA approval for, where in Prosomnus, we're going to do a oral appliance therapy on just severe patients. And they're going to have a level 2 study. It's level 2 study has an EEG electrode, so you can truly stage sleep. We're using the General Sleep Z machine for it. And all those patients are going to have studies done prior to oral appliance therapy and 2 efficacy studies. And the whole idea behind this is to gather data where we can show efficacy in the severe patients with oral appliance therapy as primary therapy. And I think it's going to take about a year to year and a half to complete this study. The majority of the patients are going to be through my office. I think Mark Murphy in Detroit's going to participate with it as well. And if we can show, and again, it goes back to that shares criteria. We don't have to show AHI less than 5. We have to show efficacy similar to shares criteria, similar to what the FDA approved for Inspire. And I think if we're able to prove that, which I think we'll be able to do, it'll be absolutely monumental for the industry, because it'll allow us to have an indication primarily for the severe patients, not have to be a failure of CPAP. So there's a lot of pressure on me with this study. It's going to go live pretty soon, I think, the next month or two. And I think you may know Erin Mosca from, used to be with Zephyrs. She's joined ProSomnus. She's going to coordinate the research, and she's been helping with it. So that study is going to be very important to the industry. And hopefully it'll work as we think it'll work.
Sorry if I seem to be a distracted moderator. I'm trying to read a tiny little chat box and answer with my one finger typing skills. But something you said stimulated a member talking about his experience in trying to advertise. I tried monthly physician newsletter, cost a fortune, gave up after 3 years, then tried radio. Everyone knows who I am, but no one came for therapy. So there you go. I'm not sure where this man lives, but obviously somewhere in Canada. So we've all tried different approaches. Like you say, it's going to be a long time till it's an equal playing field. And
yeah, you know, I think marketing, there's people that have been very successful with marketing and advertising. Obviously, there's the lunch and learns, there's the calling on physicians. And I think that maybe partnering with your otolaryngologist is, I mean, you really want to get patients into the funnel who have OSA, who have been tested, who need an oral appliance. And what works in one province or one state in the United States may not work in another state in the United States. And I think it has to be catered to what may or not work in your individual area regionally, I guess.
No, I agree totally. And I have a lot of good working relationships with a lot of medical specialists. And I just get the sense that maybe it's only an Ontario thing, but I almost get the feeling that ethically they're not allowed to say, I'm going to refer you to Dr. Rawson, but you need to see a TMJ guy, or you need to find somebody who makes oral appliances. Have a good day, you know. And I think, well, come on, that's crazy. But is that a problem? Do you know, is that ethically? Because I have no problem sending my patient to a particular physician if I want them to be seen.
Well, no, in the United States, we have something called Stark laws, and Peter Stark was a congressman from North Carolina, and there are two, Stark 1 and Stark 2. There may be a Stark 3. It has to do with physician self-referral. In other words, you cannot refer, it's an anti-kickback law, basically. So let's say that you have a referral from your physician, and then you pay him a portion of the fee. That is clearly a Stark violation in the US.
Okay.
You know, now there have been certain things, like for instance, for Medicare in the US, you cannot be a testing facility and a DME component together. So in other words, if you're the entity that tests the patient, which with an HST or a PSG, you cannot deliver the PAP therapy, same entity. And the reason why they have it that way is they say that, well, you know, that will influence the treatment. And, you know, when I discussed it with my wife, she goes, well, it's objective, isn't it? You have a sleep study, and if it's positive, it's positive. Why should it matter who provides a DME component? But I say, look, logic is not necessarily the way governments work, you know, and
right.
You know, it would be best from the DME component if it was done by the lab, you know, but it's not allowed.
Yeah, that's right.
Some of the models you're starting to see now is dentists operating in a physician's office. It's like, for instance, in a cardiology office or a sleep clinic, you have a dentist that physically he or she is in the office, and, you know, has a dental chair there with whatever equipment they need, whether they do impressions or scanning or whatever. That has to be set up legally in the US because again, the physician can't profit by sending it to the dentist can't profit by, you know,
right.
These things just make it more challenging.
Right. Well, listen, Dr. Sall, it's been a wonderful, enlightening experience. As I said at the outset, I don't think we've ever had someone who's educated and practices on both sides of the fence. You bring such credibility. You live your life with passion. Thank you so much for what you brought to us tonight. I'm sure there'll be need to invite you back again. So from Canada, a warm thank you, and enjoy your golf in Arizona, because we still have lots of snow here.
Okay.
So
Well, thanks for having me. I'd be happy to help out in the future.
Thanks so very much. Bye now.